So let's go ahead and get started. So welcome everyone. Today's webinar is made possible and sponsored by Mankind, and it's a company that's revolutionizing diabetes management by providing a fast-acting, convenient insulin option that really helps improve blood glucose control without the need of injections. Our guest speaker today is Dr. Diana Isaacs. Dr. Isaacs is a PharmD and a leading endocrinology clinical pharmacy specialist. She's the co-director of endocrine disorders in pregnancy and the director of education and training in diabetes technology at the Cleveland Clinic, Endocrinology and Metabolism Institute. With a doctorate in pharmacy and multiple board certifications, she is recognized as a national leader in diabetes care and education. Please join me in welcoming Dr. Diana Isaacs.
Great. Well, thank you so much for joining me. Thanks to Diabetes Sisters for inviting me to speak today. And I'm excited to talk about a treatment option that I think many people with diabetes don't know about. So the title is Exploring Inhaled Insulin, Benefits, Usage, and Beyond. And as I'm talking, if you've got any questions, feel free to put them in the Q&A. We should have plenty of time to answer any questions that you might have today. So what are we going to be talking about? Well, for starters, we're going to be describing inhaled insulin and how it works and potential advantages over injectable insulin. We are going to discuss how to actually use it, as well as summarizing some recent clinical studies and safety data. Don't worry, I'll try to keep it interesting. And then we're going to explain some special considerations for women. And I've got a couple of case examples also to share with you as we're going through all of this information. So to level set everything, let's just go ahead and talk about the current state of diabetes. And the reality is that it is not great, unfortunately. More and more people have diabetes than ever. The latest statistics show that 37.3 million have diabetes. That's 11.3% of the US adult population. The rates are even higher with older age. Another 38% live with prediabetes. So that's almost 1 in 2 people that has prediabetes or diabetes. Now, most of these cases are type 2 diabetes. About 5 to 10% are type 1 diabetes. But we know that anyone with type 1 for sure is going to need insulin to live. And many people with type 2 diabetes do require insulin. And I know we've had breakthroughs with our different medication classes, our GLP-1 agonists like Ozempic and Mounjaro. But even with those drugs, when people have been living with type 2 diabetes for a long time, and we hope they'll live nice long lives. But when it's been 20, 30, 40, 50 years, it is natural that they will require insulin to be able to reach their glucose targets. Now, how are we doing, by the way, with reaching those glucose targets? Unfortunately, we are not doing great. So one of the ways that we assess it is through the hemoglobin A1C, and this is a lab test that we typically check every 3 to 6 months. And the goal for most people is to have an A1C that is under 7%. Only about half of people living with diabetes actually reach that goal. And sometimes we'll say, well, if this is an older person or someone that maybe has a higher risk of having low blood sugars, we will change that goal and say less than 8%. But even with the less than 8, still only 75% are reaching that, which means 1 in 4 people aren't. So all this to say is that we need more tools. Clearly, the things that we have now are not working for everyone because so many people are not reaching their blood sugar targets. Now, I've been talking a lot about A1C, but we also have another way that we can really check blood sugar, and that, thankfully, due to continuous glucose monitors or CGM, we get time in range, and that is the percentage of time spent between 70 and 180. And so that's another way we can look at blood sugars where we're aiming for at least 70% between that range. And every 10% increase in that range actually correlates very well with a drop in A1C by about a half. So that's another way, and that's a way that we're frequently looking at blood sugars, especially for anyone that's taking insulin. Okay. So now let's talk about insulin. And insulin has gotten a little bit complicated over the years because we have so many choices. However, even amongst all of those choices, almost all of them are injected, except for the one we're going to talk about today, right? So for long-acting insulins, we've got degludec or Tresiba, we've got glargine, which now has many names to it, depending on the company that is making it. And we have Detamir or Levemir, which that one's actually going to be discontinued by the end of the year. Now, most people, if they're not on a pump, they're going to use a long-acting along with a rapid-acting insulin. And for rapid-actings of the injectables, we've got Lispro, we have Aspart, and we have Glulisine. A couple of ultra-rapid actings like Fiasp and Lumjev. And then there is intermediate-acting insulin, which has been around a bit longer and not as commonly used. Most people, if they're not on a pump, are going to use that long-acting and rapid-acting. And for those that are on pumps, they're typically going to use that rapid-acting within the pump. So what are some limitations, though, of injectable insulin? And unfortunately, there really are many. A big one is scar tissue develops. And this just happens with long-standing use of injectable insulin. When you're injecting, there's only so many sites you can use, right? I mean, we encourage people to rotate. You can do your stomach, the back of the arms, the front of the sides of the thighs. But even so, right, if you've had diabetes for a long time, you're using a lot of sites over and over again. We do encourage things like using the smallest needle size. That can certainly help, but many people do develop scar tissue. And the problem with that is it can lead to great inconsistency in how you're absorbing that insulin. And so at one point, depending where you go, maybe you'll absorb all of it. And another time you get some scar tissue and it doesn't get readily absorbed. And that can lead to erratic blood sugars where it's going high, it's going low, you don't know why. And that can be really frustrating. The second limitation is the injection burden. I mean, having to constantly pull out an insulin pen or insulin vial and syringe, if using the pen, having to attach the pen needle, and just going through that whole process, trying to figure out where to give the injection. Can you just do it in front of everyone? Do you feel more comfortable going to a private space? If so, is there a private space that is clean, that's readily available? And unfortunately, that can be challenging to have to step aside and say, oh, my blood sugar's high, or I want to eat this. And so that can lead to just missing injections because maybe it's just inconvenient. Of course, some people just forget, but some people make the calculation that, hey, I don't have a safe or private place that I want to do this, and I'm just going to skip it. I'll skip lunch, or I'll try to eat less carbohydrates. And so all of this is just really, really inconvenient. And so having other options like an inhaled option can really, really offer something different. In addition, though, there's another major, major concern with insulin. So I think what a lot of people don't realize is that insulin has what we call a narrow therapeutic window. So what is that? That means that just a little bit too much or a little bit too little can cause the blood sugars to either go way too high if you don't get enough insulin, or cause it to go way too low if you get too much. And unfortunately, because of that, because of the difficulty in dosing insulin, we actually accept that a certain amount of low blood sugars is just par for the course. That is just normal. And to prove that, when we look at our guidelines of what is recommended, if someone's wearing a continuous glucose monitor, our guidelines say that the goal for less than 70, which is what's considered low blood sugar, less than 4% of the time. So what does that mean? Well, 1% of the day is 15 minutes. So essentially, what our guidelines are saying is that up to an hour a day spent with low blood sugar is okay. And why is that okay? Well, because we know that if we completely get rid of low blood sugars, that what's going to happen is they're probably going to end up being too high. Now, our guidelines do say that less than 1% of the time should be below 54, which is less than 15 minutes a day. But that's still like when someone's below 54, usually they're not able to think clearly, and that causes a lot of symptoms. So it is very challenging to dose injectable insulin. And because of that, we see hypoglycemia. 2 episodes of symptomatic hypoglycemia occurred per week in people with type 1 diabetes. 1 episode of severe hypoglycemia. And what does severe hypoglycemia mean? That is when someone is not able to resolve it on their own. They need help from someone else to either give them glucagon or to help them remember that they need to eat or drink something. So that is truly, I mean, that's an emergency situation. And there's a 1.5 to 2 times increased risk of death and cardiovascular disease from hypoglycemia in both people with type 1 diabetes and type 2 diabetes. And the thing to know here, I mean, I hate giving these doom and gloom statistics, but we have to be really careful. We don't want to cause so much hypoglycemia to occur. And one of the challenges with using injectable insulin is it doesn't work as quickly as insulin from someone without diabetes with a healthy pancreas. That insulin is going to work quickly and it's going to be out of the system. And that is the reason that most healthy people without diabetes, they're not experiencing low blood sugars or hypoglycemia. So that brings me now to introducing inhaled insulin and truly why this is so revolutionary and why we need an option that is not injected. So with inhaled insulin, it passes through your lungs into your blood and it starts working to lower blood sugar very, very quickly. It doesn't have to wait to get through those layers of the skin like injectable. Now, it is FDA approved to improve glycemic management in adults with diabetes. So this graph, I'm going to explain to you what this means. So what you are looking at here is actually a comparison of inhaled insulin, Afrezza, to one of the rapid-acting insulins, insulin Lispro. And what you're seeing here is the mean glucose concentration, or the mean insulin concentration, actually, and then you're seeing the amount of time. And what you will notice is Afrezza peaks. It peaks much more quickly than the insulin Lispro. And look, it is out of the system much more quickly compared to that Lispro, which actually is hanging around. It can even hang around up to 7 hours. Usually higher doses are going to cause it to take a little longer to work and work a little bit longer in the body. And so that tail is hanging around for much longer. And the time to peak for inhaled insulin was actually shown to be 42 minutes compared to 93 minutes with a comparable dose of insulin Lispro. So that is a big, big difference. So to further illustrate this, in this table, what I have here is what is the onset of insulin in a healthy individual with a working pancreas compared to inhaled insulin compared to injectable insulin. And let's just start off with the onset, right? 10 minutes, healthy individual, 12 minutes with inhaled. That's pretty close. That's pretty near identical. Injectable, 17 to 30 minutes. This is one of the reasons that we constantly advise people to do what we call pre-bolus, that you can't just wait until you've started eating, that we want you to remember to inject your insulin at least 10 to 15 minutes before you start eating. And we know in the real world that is pretty challenging to do. You may not know exactly when you're going to have time to eat or when your food is ready. So that is a tough thing to do. Now, the peak. You look at this, healthy individuals and inhaled insulin, 45 minutes to peak. Those are the same versus injectable, 90 to 120 minutes. So what that's meaning is it's peaking at the wrong time. And so usually what happens is blood sugar ends up rising quickly, and then the insulin is actually playing catch up. And if you add to that the fact that if someone didn't remember to pre-bolus, it's going to go higher for longer, and then it's really going to take longer to catch up. And then what about coming back to baseline? Ideally, we want it to come back to baseline quickly. We don't want that insulin just hanging out in the bloodstream. causing low blood sugars. And here, actually, the inhaled insulin is out the quickest. It's 180 minutes compared to 210 minutes in healthy people. And then injectable insulin is actually up to 320 minutes. So it is hanging out a lot longer, and it can be even longer than that with higher doses of insulin. So that's great, right? But how does it actually work in a person with diabetes? Well, let's take a look now at some of the data. And what you're seeing here, this is comparing Afrezza it's comparing Afrezza to what's called rapid acting insulin. That's what the RAI stands for. And it's showing you what that glucose or that blood sugar is a certain period of minutes after eating. So starting at 0, that is the meal time, right? And we see that when you take Afrezza, actually the blood sugar has gone down after 60 minutes. And with taking the rapid acting insulin, that's the orange line, that it's actually initially it's going up. And they may end up in the same place, but immediately after eating, that 1 hour after starting the meal, which is often when blood sugar peaks the most, we can see that it was much lower with Afrezza compared to using an injectable insulin. So less likely to have those post-meal highs. There are also less lows, though, with inhaled insulin. And so what this is showing is comparing, again, rapid-acting insulin to the inhaled insulin at different amounts of hours after eating. And so what you'll see here is that there were less lows when you compare really all of them at different weeks of the studies, that there were less lows. There were specifically lower rates of hypoglycemia from that 2 to 5 hour post meal. And this is a time where people are really, they're likely to have a low if their insulin is mismatched with what they're eating, and they end up, it starts working too late and it ends up sticking around for too long. It makes them much more likely to have a low several hours after they are eating. So there was recently this really unique study that was presented at the ADA scientific sessions, and this is called the INHALE-3 study. And basically, the question was asked: is inhaled insulin as good as automated insulin delivery, right? And automated insulin delivery, so that's insulin pumps that are communicating with CGMs to automate insulin. They are awesome. They are awesome, awesome options. And so this, I think, is a really interesting study comparing the two. I mean, should everyone just be on an AID system? So this was a 17-week randomized control trial. And what that means is that over 17 weeks, some people were told to go ahead and continue their current system, their current AID system, and others were actually switched to using a long-acting insulin along with the inhaled insulin Afrezza. And so they compared outcomes. They were looking at things like what percentage of people were able to get A1Cs less than 7%, and what was the time in range from group to group. So more people using the inhaled insulin actually were able to reach their glucose target. So 30% of those on inhaled insulin had an A1C of less than 7% by that 17-week mark, compared to 17% that were in their usual care group. 21% of inhaled insulin versus 0% in the usual care group made that A1C goal of less than 7 if the baseline, meaning their starting A1C, was over 7%. And then 24% of the inhaled insulin group was able to achieve that time in range over 70% compared to the 13%, along with having no increased risk of hypoglycemia or low blood sugars. So I think this is really interesting data, and I am not suggesting that everyone should now give up their insulin pumps and use inhaled insulin. But I think that there are many people, for whatever reason, that may not want to be on an insulin pump or may not want to use one of these systems. And I think this is showing, for those that, for whatever reason, choose not to use one of those systems, that there is a good option where someone could be on a once-a-day long-acting insulin and then use inhaled insulin for their meal times. All right, so let's talk about some more benefits and some additional things to consider. So there's no pre-bolusing required. So with inhaled insulin, you can truly just take it at the start of the meal. That's how it's designed to take food in your mouth, inhale it. Usually, though, the dosing's a little bit different. So if you, for example, were used to taking 4 units with your meal, like 4 units of aspart or Lispro, you typically are going to need at least 1.5 times that and maybe 2 times that. So it'd be very normal to need 6 to 8 units with that meal. It, of course, reduces the injection site use and risk for scar tissue. This should always be used with the long-acting insulin for people with type 1 diabetes, but that now we've reduced it to once per day, and there are weekly insulins in the pipeline, so that in the future it could potentially be once a week, right? And I think there's a lot of different use cases. It's not all or nothing. It's not like, okay, you have to replace all of your mealtime insulin with this. I think that's one thing that could for sure be done. But also it could be like, okay, I'm going to use this when I am going to have like a food that I know is going to spike me really quickly, like a higher glycemic index food, like that bowl of cereal you're just really, really craving, or that Slurpee you just want and have to have, right? Because it's going to work so quickly. Also, it could be reserved for correction doses. So you could still use your mealtime insulin, your rapid acting injectable insulin, but as we know, that is far from perfect. And if you end up spiking a little too high, or it's stubbornly not wanting to come down, go ahead and inhale, and that will bring it down much, much more quickly. I think there's some use cases for using it along with insulin pumps. I think for this, it is a little bit more nuanced because some automated insulin delivery systems will handle it better than others. So that would be considered an off-label use, but for certain types of pumps, that could work well. And certainly if using just a totally manual pump that's not automated, that can work. And then also for a meal or snack prior to exercise, if exercise is going to be happening in a couple hours, think about it's going to be out of the system more quickly, less likely to actually dip too low. Now, what are the side effects? So thank you all so much for answering those questions in the beginning. It was very helpful. And I know some people raised the point, well, like, what are the side effects of this? Is it different? So of course, with any insulin, there could be low blood sugars, but we saw already how it's less with inhaled versus injectable. Now, there are a couple of things that are different. Cough can occur. The first time you inhale anything, right, you may cough because it just feels a little bit different, right? So the good news is most cough is really mild. It usually occurs with the first inhalation. Usually it's temporary, and then with continued use, it declines. Usually most people are not still experiencing that. When it comes to actual people that stopped using it because of the cough, it was only 2.8%, so a very small amount of people. And then the other thing that could occur in slightly higher amounts is just a little bit of throat pain or irritation, but that was pretty low when they looked at that in the clinical trials. But those would be the most common potential side effects. Now, if you dig a little deeper, you will notice that there is actually a black box warning on the inhaled insulin, and that is this risk of acute bronchospasm in patients with chronic lung disease. So we do not generally use this in people that have lung disease, so including things like asthma, that have COPD. We would not want to use that in those situations. And because we want to be really safe and make sure someone doesn't have those conditions, we do a test called FEV1, and that just helps us check to make sure the lung function is kind of where it's supposed to be, and we can continue to monitor that throughout use. But the good news is that there was no significant safety concerns identified across 13 clinical trials in people that were taking Afrezza. And even upper respiratory tract infections did not impact someone's ability, someone's dosing, what they were getting. It still was safe to use in that situation as well. So if you're going to be using this and you're going to be switching, it's helpful to understand how the dosing differs. And there's these really helpful dosing charts. And we also created a tip sheet, which can help it has this on there as well. So when you're doing injected mealtime insulin, so you're going from your rapid acting insulin, if you were on up to 4 units, you're going to go ahead and use 4 units. The smallest dosing size is actually 4 units. It comes in 4, 8, and 12 unit cartridges. And while that may seem, oh, that's kind of high, remember that's really more like 2 units. Then if someone's on 5 to 8, they would go ahead and start with 8. But keep in mind, these are starting doses. We try to err on the side of caution because we don't want to end up giving too much and cause a low blood sugar. On the right, after the starting dose, you can see the anticipated dose. And so we know for many, many people, they'll typically may require about twice as much, at least 1.5 to twice as much as what they were getting as an injectable. And it's really more of an art than a science. You might be thinking, well, wait, my pump can give me like 2.16 units. Like now you want me to round to 4? It is more of an art. It brings down blood sugar. You don't have to have strict carbohydrate counting. And if you need to, if it didn't bring it down enough, you can redose as early as an hour. Normally, with injectable insulin, we try to encourage people not to dose after an hour because we worry about stacking insulin, where if you keep giving more and more and more, it doesn't work right away, and then it starts working, and then you go low. With this, if you see that you're high after an hour, you can give more. You don't need to wait and just sit and watch it stay high. And there are some dosing recommendations for how to do this. So for example, if you were between 151 and 200 an hour after eating, you could go ahead and take another 4 unit cartridge. If you were over 200 at 1 hour, you could do an 8 unit. And if it was by 2 hours, you could do 4 units. This was done in one of the clinical trials and was quite effective to bring down blood sugar. All right, so how do you take this? How big is this thing? It's really small. You see that little hand there, right? It fits on your fingertips. It's pretty tiny. And this, by the way, is revolutionary because for anyone that's been around long enough, there was previously an inhaled insulin. It was called Exubera. It was around in like 2005. It was like the size of a bong. So needless to say, people did not feel comfortable carrying that around with them when they went out. And so it went off the market. The uptake wasn't so good. This is really small. This can just be in your pocket. It can be very discreet. And so people really like that. You can see the instructions here. The inhaler is actually designed for just 15 days use. So other than wiping it off, you don't have to worry about like sanitizing it and all that. If you lose your inhaler, you'll get another one. So not a big deal. Tiny little cartridges that are going to be placed within that inhaler. The cartridges are designed for one-time use, and you can get packages depending on what your dose needs are. You can get all 4s, all 8s, or all 12s. You can get a combination pack, so you can really kind of play around with it and everything. And then on the next slide, when you're ready to inhale the insulin, you're going to take off that cap and everything. You're actually first going to breathe in and exhale, and then you're going to position it, and you're going to really inhale it and try to take in a deep breath. Hold it as long as you feel comfortable. You don't need to go crazy or anything. And then you're going to exhale it. And I think the key here is really the consistency with how you're breathing it in, and then you will get a consistent dose with it. You don't have to stress about exactly everything, just as long as you're kind of consistent with how you breathe it in, how long you hold it in, and exhale, you should get consistent dosing. In terms of how it comes in these packages. Generally, if it's not in use and you just have an unopened package, just like with other insulin, with insulin pen packs, you'd go ahead, you'd store it in the refrigerator. Once you've opened up those, taken it out of the package, it's good for a month. And then the sealed blister cards and strips, if you have those out, you would want to use those within 10 days. So usually you're going to pull out what you plan to use over the next few days. And then if you've actually opened it and you can see that cartridge coming out of the foil, then you try to use it within 3 days. One thing to note, and I did learn this the hard way. I learned everything the hard way, but you don't want to take your inhaler with the cartridge in it and start shaking it. That will cause the powder to go everywhere, and then you may inhale random pieces of powder. So we don't want to shake it. We just want to put it in and then breathe it in and breathe it out. I did not intentionally mean to shake it, but I was sometimes I moved my hands a lot and I started shaking it and the powder went everywhere. So don't do that. All right, now but this is Diabetes Sisters, right? So let's talk about some special considerations for women, right? So we know around the menstrual cycle, there can be changes in glucose. And this is very individualized, but many women may notice things like their glucose needs go up the week before their period comes. They seem to have more resistance. Maybe the week of their period or right after, they may be more sensitive. And so having a little extra tool in your tool belt could be really nice to supplement what you're usually doing. And we've tried other things. I mean, you can always try to increase your rapid acting injectable insulin with meals, or maybe try to increase your long acting a couple units, or try to adjust your pump a little bit. But it's really, really challenging to do that. And many times those strategies lead to low blood sugars. And so having this extra tool to be able to correct a high blood sugar as needed could really be very, very helpful for those times. I do want to emphasize that inhaled insulin is not FDA approved for use in pregnancy. It is something being investigated, but it is not approved for use. It just hasn't been studied for safety in pregnancy. It is made of regular insulin, so we know insulin is generally safe, but there are some additional things in there that would just need to be studied to get approval for pregnancy. All right, so let's close off with some patient cases. And here we have Sheila, who is 26 years old, has lived with type 1 diabetes for 14 years, and her period is really irregular. So, but she can tell it's coming because her glucose levels will generally start to rise the week before. So current meds include, she's taking a long-acting insulin, insulin degludec, 24 units once a day. And then she takes the rapid-acting insulin, insulin aspart. She follows an insulin to carbohydrate ratio of 1 unit of insulin for every 12 grams of carbohydrate, and then an insulin correction factor of 50, meaning 1 unit of insulin to lower her blood sugar by 50 points. So she's tried to increase her doses of insulin, but it always ends up like not working out. She goes low, or maybe she thinks her period's coming and it's not coming. And so this has led to a lot of frustration. Overall, her management, her A1C has been 6.9%. But here we can see her CGM data. Despite a 6.9% A1C, she's actually only about 58% in range, and she is experiencing a good amount of time lows. And we can see that this was like leading up to her period. She had some larger spikes, and she tried to play around with her long-acting insulin by raising it a couple units, and it just kind of backfired. And especially with an insulin like degludec, which is in the body for so long, it's just increasing it may not have effects until a couple days later, and that may not be when you want to see those effects. So she was introduced to Afrezza, to inhaled insulin, and she first started using it when she was getting her period, and she really liked it to correct her high blood sugars. But ultimately, she found she really liked the convenience, especially when she was out and about during the day, and she ended up using it to actually just replace her rapid-acting insulin. And what you can see on here is her time in range has really dramatically improved. She's now 87% in range, and just having a whole lot less spikes. Yeah, there's still sometimes her blood sugar goes higher. She has type 1 diabetes, right? But it's really, she's had several days where it's just stayed in between those lines the whole day. And so this has really been much more convenient and also really improved her blood sugars. Now, one last other kind of little tidbit case I wanted to share with you is just when you're looking at it, like in the moment, how can inhaled insulin be used throughout the day? And I wanted to emphasize again that it is more of an art than a science. So let's say you're wearing your CGM, right? And you're kind of rolling through the day. And let's say it's Tuesday, July 30th, and you're home, you're like, you know what? I'm just going to use my injectable insulin. I'm having my usual breakfast, fine, fine. Maybe you're really stressed though, and things are not going your way. You did not get a good night of sleep, and you notice, oh my goodness, it is rising. It has gone up so high. I don't understand. I'm doing what I always do. Boom, you inhale some insulin, you can help to bring it down much more quickly, as opposed to then deciding, is it safe to give another bolus? Because I know the insulin's still working. How long should I wait to watch it go high? Are the arrows continuing to go up? Are they coming down? And you can just take care of it. You don't have to think about all of those things. Looking at Wednesday. So Wednesday's a day where it stayed in range. And why did it stay in range? Because acting quickly. You don't need to wait for it to go high to act. If you see those trend arrows going up, inhale some. You don't need to wait for it to get high to do that. You can do things like put your rise rate on if it's rising really quickly, or maybe you choose to look at it when it's 180 and you see, oh, the arrows are going up. I don't want to wait till it gets to 180. I want to act on it now. And you really can do that to more easily stay in those lines when you've got a fast acting insulin tool like that. So just some key points to really leave you with. Inhaled insulin is truly the fastest acting insulin and is the most similar to a person without diabetes. And honestly, if we had the ability to put inhaled insulin in insulin pumps, we would do it, but we can't because it's inhaled, right? It reduces those post-meal spikes and corrects high blood sugars very quickly, much more quickly than injected insulin. It can be dosed again quickly within 1 to 2 hours without worrying about lows from stacking insulin. And it may be a good tool to have on hand for any times in your life where insulin needs may just be a little bit higher. And with that, I think we'll open it up to questions now.
Very good. Thank you, Diana. That was a fantastic presentation. So I'm going to give everybody a few minutes to go ahead and put a question if you have in the Q&A. And I just want to say thank you. It was great. I know a lot of our members, Diana, have really kind of know the art of self-management and have really worked really hard to get there. And so I think adding inhaled insulin in their toolkit is a great asset. And I know many of them said that they weren't familiar with it. So I think this is really, I think, great for them. And we have a good population that would be really willing to kind of add another therapy, right, to really help with those highs. So please put your questions in. We do have one question, and I know, Diana, you answered the one about side effects, but this question is, can inhaled insulin be used alongside all automated insulin delivery systems? And if you could just talk about that a little bit.
Yeah, so it's a good question. And the challenge with that is that some of the systems really base their automation on total daily insulin dose. And so when you're getting a lot of your insulin outside of the pump, it's going to mess with that total daily insulin dose. And so I'll give you a couple examples. So Omnipod 5 is one of them where that total daily insulin dose is really, really important. And so if you are receiving a ton of your insulin boluses outside of the pump, it's going to limit the ability of that algorithm to increase. And so anytime that you go higher, it's going to be a struggle to get back into goal. And so it may lead, unfortunately, to not reaching the glucose targets as much as you want to. Now, other systems, like, for example, Control-IQ, Tandem's Control-IQ, that's a very different type of algorithm. And it is running, it's actually using a lot of the current settings, like the basal rates and the correction factors. And so that one tends to work a little bit better if you're using it with that system. I think, though, one thing to keep in mind with all of the systems is that there's no way to tell the system, oh, I took inhaled insulin. So if you just took it and it hasn't worked yet, and then the pump sees that you're high and gives you additional insulin, it's not going to know that there's like what we call insulin on board. So with any of the AID systems, there could be an increased risk of going low. And so that's just something to keep in mind, but some will work better than others.
Great. Okay, we have another question. How do you determine when to take an additional dose of Afrezza if your post-meal blood glucose is high? And I think you touched on it, if you could maybe summarize that again. So
sure. So there's one dosing strategy which was used in the study that basically 1 hour after, if you're between 151 and 200, to just take an extra 4 units. If you're over 200, to take an extra 8. But this, again, this is going back to the art. It's going to be some trial and error. And this is really a great opportunity to work with like a diabetes care and education specialist or working with your healthcare team to figure out the patterns. But it will vary. I mean, if you need higher doses, then it could be that you may need more than 4 units despite being at 180, for example. So, and it's also about looking at the arrows, because like 180 with arrows heading up is very different than 180 with arrows heading down. If it's 180 and arrows are heading down, you may not need any more. You just kind of wait it out. So it is kind of more, it's so much less of this strict, like, okay, how many carbs are in here? Do we need to subtract the fiber? Like, it's not like that. It's truly like, it works the best if you've got a CGM and you can just look at it and kind of make a judgment call. Oh yeah, I'm staying high. Let me try another 4 units. If that wasn't enough, I can always do 8. Or maybe you say to yourself, wait a second, I'm going to be going for a walk, or I'm going to be moving more. I think I'm going to hold off. So there's a lot of this self-management involved with it.
Yeah, and it does simplify it a lot. Like you said, the whole carb counting is so difficult sometimes, right? And the fiber and all of that. So
Right. We're really moving away from that because we know even with perfect carb counting, there's nothing perfect about it. Like it just, yeah, there's so many
and
variables.
most people eat the same thing every day. So seeing that too. We have
Yeah.
another question, Diana, from Cher. I was diagnosed 4 years ago, 62 years now, or years old now, and doctors have never mentioned this to me. I do have insulin, I do have issues with grazing, but still struggling. Would this be perfect for me while I am still struggling with the behaviors and have a history of lows for 3 years? Better now, though. Mhm.
Well, it sounds like you'd be a very good candidate to try this. And going back to, I think unfortunately a lot of healthcare professionals don't know about this or they don't remember it. It's kind of like one of many options and they don't think to mention it in the 20-minute visit that you have with them. So it's really good to be empowered to attend webinars like this and bring it up to your healthcare team. Just based on the information that I'm hearing, I would think that this can be a great option to try, that it can help with the lows and give you a little bit more flexibility with the eating. But of course, we just have to make sure in terms of like you don't have asthma, COPD, and checking those things. So definitely check with your healthcare team.
Very good. And another question from Danielle. The difference between Afrezza and other ultra-fast acting insulins is just that Afrezza is inhaled. That's the question. Are there any other differences, or probably in?
Yeah, so it's inhaled versus injected, but then the onset is much faster, and then the in and out of your system is much, much faster. So it's much more like insulin from someone with a healthy pancreas compared to injectable, which just takes too long to work and leads to more low blood sugars.
Good. Okay, and another question comes in. What is the cost compared to injectable insulin, if you know that?
Yeah, so it's comparable. It always is going to depend on insurance coverage. I know that there is a program for people that don't have insurance coverage. Many times, I'll be honest with you, many times it does require a prior authorization. And on there, they may want to see things like why, like most people have already tried injectable insulin. So kind of why you don't want to use it. And it could be a variety of things. It could be the low blood sugars, the difficulty with the dosing. And then generally the coverage on that can be good if you can explain that. There is, just so you know, I touched on this, but this test that you do, it's called FEV1 testing. It's a very quick test. You basically blow into this device 3 times. It's just checking your lung capacity. And generally, they want to see one at baseline. So if it gets denied, it could be like they need to do that test. And this is on the tip sheet, but the company will even mail one to you if they won't do it in your office. And then usually they want to see one of those just once a year. So that's just something to know.
Yeah, and that was the last question about the pulmonary functions test. And then how often during treatment do you need that?
Yeah, and I think like this gets misinterpreted, and this could be one of the reasons it's not prescribed more, is people hear that and they're like, oh, I gotta send to a pulmonologist. This is so much work. No, it's a really simple test. It's this peak flow meter you can keep in your office. It's very small. You blow into it 3 times, so it's like less than 2 minutes. But you should do one at baseline. They usually want to see one at 6 months and then once a year after that. That's something that the FDA wanted to see. But we'll see. I mean, I think we're all hoping that the label would ease, but that is something that should be done 6 months and then 1 year.
Very good. Okay, thank you, Diana. That was the end of our questions. This has been great, a lot of valuable insights. Diana has also created a tip sheet on inhaled insulin, and a lot of the information she talked about is on that tip sheet, so you can download that from our website under the resource section. So again, a big thank you to our sponsor, Mankind, for their generous support and sponsorship for this program, and a big thank you to Diana Isaacs for this excellent presentation. Remember to download Diana's tip sheet on inhaled insulin from our website and go to our website to sign up for these next upcoming events. So thank you all for joining us and hope to see you at our upcoming events. Have a wonderful day. Bye-bye, everyone.